Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out and return the program evaluations. Give us any ideas that you might have in regards to future topics or future speakers. Today, it's my pleasure to introduce actually two co-presenters. Joni Williams, RN, who is a palliative care nurse and coordinator for the palliative care program here at Mary Greeley, and Larry Otteman, who is a hematologist oncologist and also co-director of the Homeward Hospice House. They've kindly accepted our invitation today to update us on palliative care, and the title of their speech today is "Not Everyone Needs Palliative Care, but More Than You Think." And please join me in welcoming Joni Williams and Larry Otteman.
Thanks, Steve. Good afternoon. There are very few slides, as you can tell from your handout, so both myself and Joni would appreciate lots of dialogue and questions, so we'll be moving on. So what I hope you come away from this meeting with today is a good feeling about palliative care. The other is to identify in your minds, is this a patient I should be thinking about palliative care? We'll describe to you what we can provide at Mary Greeley and what people consider to be acceptable or standard of care for palliative care. Joni's going to spend time doing what I think is the most important thing about palliative care, and that is kind of talking about cases, patients and families. Excuse me. One of the things that bedevils people who are in palliative care is trying to justify their existence financially. Because much of what we do in palliative care is to have long, detailed conversations with patients and their families about what they do and don't want done. And in the current payment environment, we still largely, hospitals, physicians, get paid for doing things. We don't get paid for not doing something. And many times, what patients and families choose, rightfully so, is to not do the very last test that could be done or the last treatment that could be done. And it's nearly impossible to capture that information. Now, people are trying, and we had a speaker about 6 months ago from La Crosse, Wisconsin, who have a very vigorous palliative care program there, and could show just through Medicare data that Medicare patients at the end of life in La Crosse, Wisconsin cost less to Medicare, cost Medicare less, I should say, than do patients at the end of their life in Des Moines, Iowa. So there is data out there, but cases and stories, I think, are still the best way to get our message across. And then, of course, we'd like to show you how to make referrals to hospice. And that's an easy thing to do. We try to make it easy for you. Let's start with the definition, because you always do at these talks. And so this is the definition from the National Consensus Project for Quality Palliative Care. So if they don't know what palliative care is, nobody does. So you can read through that. I think the highlights of this are that it's interdisciplinary. And I know that everyone talks in medicine today about teams and interdisciplinary care. But truly, palliative care can only function in an interdisciplinary way. The focus is on quality of life for patients and for their families. And it doesn't require that patients be terminally ill. They need to be seriously ill. And they can still recover. It's okay, but they can still benefit from what we can provide in the field of palliative care. So I'm going to go through some guidelines that were constructed by this organization, CAPC, which is the, I forgot the first word, Joni. The Center for the Advancement of Palliative Care. Thank you, sorry. Diane Meyer's group. So these are people that if you're an emergency room nurse or if you're an emergency room physician, and even if you're maybe the hospitalist who's admitting this patient from the ED, what should be the things that at least lead you to ask the question, should this patient be involved in a palliative care program? And they're not very complicated. The patient's coming in for the umpteenth time for the same problem, which isn't going to get any better or only gets better transiently. Is this a long-term care patient from a nursing home who's already made the decision that they don't want a lot of aggressive care with a do not resuscitate order? And was this transfer to a higher level of care in accordance with their wishes? It may not be, and sometimes that's important to get established. Is it someone who's already expressed a desire to be involved in a hospice program to maybe end this cycle of coming back to the hospital, but it just never has happened? And then there are specifically some patients in the intensive care unit that should at least, again, trigger the thought about maybe palliative care should get involved in this patient, in their care, and with their family. Metastatic cancer with declining function, moderate to severe dementia with a serious enough problem they're in the ICU, or maybe just more than one chronic disease, which is very common for our patients, as everyone knows, who's wasn't doing well when they came to the hospital and are doing even worse now. So after you get through the ED, if those things haven't triggered your thoughts, what about the nurse that's doing the admission, or again, the hospitalist that's doing the admission, or if the primary care physician is admitting the patient, what things should at least trigger the thought about who should be involved in palliative care, or at least they should have a referral for palliative care? So, potentially life-limiting or life-threatening conditions is a baseline. So, somebody coming in for a hernia repair or something, don't be silly. So not everybody needs to be seen in palliative care. Most people in the hospital don't need to be seen for palliative care. But if they have something that's life-limiting or life-threatening, at least that substrata should be considered. And it wouldn't be a surprise question. If you found out that this patient died in the coming year, would you be surprised? It's amazing how accurate that is in terms of just the sense of how likely the patient will be to survive. Is this, like I said, the third, fourth time that they've come in for the same sepsis related to a Foley catheter, exacerbation of COPD, exacerbation of congestive heart failure, poorly compliant dialysis patient? Do you already anticipate that this patient's going to have problems either physically or more often psychosocially because they did the last week when they were in the hospital? So that shouldn't be a surprise. If they have catheters, complicated drug regimens, anything that makes things really complicated for the patient and family to take care of. And then if the patient's clearly going downhill, and again, this is not what we went to the medical school for. We can all walk into a person's room that we may have seen 2 or 3 months ago, and your gut instinct is, wow, this person is not doing well, and they're not going to do well. Families have the same sense. Friends have the same sense. You can walk in on a patient. You don't need to have a CAT scan to know that somebody's going downhill. Although I'm not speaking against CAT scans, they're very important. So what about the patient who came into the hospital, things looked like it wasn't going to be a big deal, but now suddenly things aren't going so well? Again, that life-limiting or life-threatening condition, and it turns out that we're not making much progress in controlling whatever symptoms they have. They've been in the ICU for over a week. And, some of those people are getting better. They don't need a consult, but maybe they're not doing better. And it's time to think about what are the goals here. And that's the big one here. What is the goal? It's very tempting for all of us that are providers to sort of say, well, my goal for this patient is to get them through my shift. My goal is to get them through this hospitalization. My goal is to get them to Friday until I can hand them off to my partner. It's what we do as human beings. And we've done that ever since we started medical school, nursing school, PA practice. We've all had a really short range look, which is, okay, I just need to get this person through the next day. And that's not serving them well. And we all know that. But busy days call for, taking whatever shortcuts you can to maintain your sanity and being able to see all the patients that you're asked to see. So oftentimes no one's really spent the time and effort to sit down with the family and with the patient and with the providers and say, where are we headed? What do you really want to get out of what time you have left? And palliative care is very good at that. Joni is very good at that. Maybe there's a disagreement, and those are not common, but they're uncomfortable when the mythic daughter from California arrives and hasn't seen her father or mother for a year and can't believe how much they've deteriorated and want to know why they can't be the way they were a year ago. If the patient has widespread cancer, especially if they're not doing well, if they've come in already from a long-term care facility because they can't care for themselves, and if a patient has the diagnosis of anoxic encephalopathy, is sort of a classic indication for setting goals. There are a number of articles that have been published really in the fairly recent past with regards to thoughts about this, experience about it, people writing about their thoughts after they've practiced palliative care and seen patients for 1 or 2 decades. And those are just the titles, and I'll give you just short quotations from them. It's nothing very complicated. So the first article, the first author, came to this conclusion: although palliative care was focused initially on patients dying from cancer, the patient population that may benefit from palliative care has expanded considerably. And I think that's recognized now. Certainly, I've been in the hospice program at Mary Greeley for over 30 years, and we did think of it mostly as a program that we provided care to our cancer patients. That's how I got involved. And much more now, we have other patients with chronic debilitating illnesses involved in hospice and palliative care. Palliative care interventions were associated with improvements in patients' quality of life and symptom burdens. That has been demonstrated time and time again with questionnaires for patients, questionnaires of family regarding their patients. It has been somewhat more difficult to show that it really makes the family feel better. And there have been some studies that show that patients involved in palliative care early live longer. Everyone's always amazed to hear that gosh, when patients don't do what we tell them would be a good treatment for them, they actually live longer, is a bitter pill to swallow. But it's true. But that's not always the case. And then Dr. Smith summarizes the consensus panel point of view that, at least in the field of oncology, and that was the consensus group for oncology, should be considered early in the course of illness for any patient with metastatic cancer or a high symptom burden. So none of these are very striking things, but these are statements that are now well supported by literature and experience. So what can we do for you? What can we do for your patients? What can I do? What can Joni do? What can the organization do? And these are the standards that are expected of a palliative care program. that there's a way for the patient to receive comprehensive assessment, thus the need for an interdisciplinary team. Address these concerns, physical problems, but it only starts with the physical symptoms. In some programs, palliative care is consulted to write the orders for morphine PCA or a morphine drip, and that's kind of where it starts and stops. Other programs, though, most programs, though, go way beyond symptom relief and get involved in the patient's psychological and spiritual issues. Palliative care is still a very good program to help with difficult ethical issues having to do with the role of surrogates, what the treatment preferences are for patient and families, and trying to make sure, again, that when you can elucidate or clarify what goals are for patients, that everything that we're doing for the patient fits with those goals. And obviously, it should not only be focused on patients, but also on patients' families and caregivers. So those are the standards that are expected. Those are the standards that organizations that review palliative care programs are going to be looking at. And those are the standards that we should hold ourselves to as well. What can we do here at Mary Greeley with our palliative care services? We don't do everything, but we're doing more. We started off as an inpatient program and now offer outpatient palliative care consultations. We continue to be involved in symptom management, although the truth is that the providers at Mary Greeley are quite good at symptom management. That's not where we have a big deficiency. The hospitalists, the medical subspecialists, the surgeons are comfortable and quite good at symptom relief. Anesthesiology is quite good at symptom relief. And so we don't get all that many consults about, what can I do to help this patient's symptoms. We're involved in hospice referral. It just makes it smoother to go from the concentrated and lengthy conversation that Joni has with patients. If the decision is made to go into a hospice program, it's natural for us to help facilitate that referral. There's actually a care conferences policy at Mary Greeley. I know we've all read that, but if you haven't committed it to memory, it indicates that palliative care should be considered in that care conference as families and providers and patients make decisions about their goals. Much of what Joni does is to have conversations with patients and families about advanced directives. I-Post, which is a specific legally binding document in the state of Iowa that comments on 3 specific aspects of care: resuscitation, hospitalization, and artificial feeding. And so that's sort of the heart of that document. And Joni has had many conversations and helps patients and their families fill out that document. And I think one of the things that's very valuable is that my observation over the years is that discussions about whether people want CPR is better now than it was 30 years ago, but still oftentimes quickly becomes a question to a child: do you want us to do everything for your father? How could you say no? Or to a patient: do you want us to do everything? Or do you want to have CPR? Without any explanation about what CPR is, what the likelihood of success is, what the physical trauma is, and so on. And it's not because we don't know, but it takes time. It just takes time to go through that, and Joni is very skilled at that. We have a very good video that's available for families. We have excellent written information that's available for families as well. So I think that if you are having a CPR discussion or a DNR discussion with patients and families, and you feel like they really need more information, palliative care is where you should ask for help. The future for Mary Greeley and other palliative care services is to try to erase all of those artificial boundaries that exist primarily due to payment. Going from an inpatient to an outpatient to home-based care, maybe even long-term care in a nursing home, or going on to hospice, so that once a patient states, these are my goals, these are the limits that I would put on the kind of care I wish to receive, that can be followed in any setting that they are. The other is that we get away from the idea that they have to have end-stage heart failure, end-stage kidney failure, and we sort of say, is this a patient and is this a family that could use the services that we provide through palliative care? And again, it's going to always require collaboration and coordination. We're extraordinarily lucky in the community of Ames and in Story County to already have a healthcare system that is as coordinated as it is. We are nearly unique in that aspect, but we can do better, and we hope to be able to do better as time goes on. So I'm going to turn this over to Joni, who's really going to share some cases with you. I'd be happy to answer questions. There'll be time at the end too to answer questions. And please ask questions of Joni as well. So any burning questions that you need right now, or otherwise we'll pick things up maybe at the end here. So thanks, Joni.
Can you hear me?
Oh, let's see.
No.
Is it on?
I thought it was on.
Yeah, it's
Yeah?
on.
Okay. All right. Let's see if I can figure this thing out. Yeah, we'll come back to that. Okay. Well, as Dr. Otteman was talking, I was making a few notes yet. I just want to mention with the hospice referrals, we are more than happy to do those. But for the physicians that put in hospice referrals that I've not been involved in, there's no need for a palliative referral. Social workers will continue to go ahead and do that direct hospice referral. So I just wanted to clarify that a little bit. A lot of what I do, like Dr. Otteman said, is sit and talk with patients, families. It's not uncommon for me to be with a family an hour, hour and a half, even 2 hours. Sometimes it's just a matter of talking with the family and helping them have conversation with their patient or with their loved one. You know, they're both maybe thinking the same things, but neither one really wants to bring up the subject or the topic of hospice or end of life or decisions or those kinds of things. Sometimes it's the patient needing help. How do I mention this to my family? How do I tell them what I want to do or don't want to do? Finding out what is important to these people is huge, and that has an impact on every decision that they make. And nearly every patient and family that I talk with, I give them the example of, I've had a lady tell me if she's laying in ICU with a breathing machine, ventilator, feeding tube, as long as her heart is beating, that's life to her. Maybe not for me, but that's not what counts. I've had other people that say, you know what, if this treatment is going to prolong me having prolonged hospitalizations or frequent hospitalizations in and out, I don't want to do that. I don't want to spend any more time in the hospital. I'm not going to do anything. I want to go home and sit on my porch. And that's what we can do. So it's just important to really find out what it is that they want to do. Goals, it could be, I want to live, I want to do this, I need to do this until my granddaughter is born. We had a lady that ultimately died here because she could not give up, if you would like to say that, on treatment. She was trying to survive until her granddaughter was born. She didn't make it, but that was her goal, so that's what we did. So it can be all types of things. It's not what I want. It's not what we as providers want. We need to pull that from the patients and the families, find out what's important to them, what's ethically good for them, what gives them quality. Recently, one other thing, and then we'll get on to some more of the patient things. The advanced directives. Advanced directives are a big piece of what I do, and just recently, end of April, I believe it was, those orders, the BPA had gone from a social work consult to a palliative care consult. So anybody that sees a palliative referral out there and it's for advanced directives, that's all I'm doing. So don't panic thinking I'm going to go in and talk hospice. And there will be some changes, a little bit of tweaking on the documentation, so you'll be able to see that. Excuse me. So let's talk about some specific patients. When we were talking about putting this program together, my task was to think of people, patients, families where I felt like I had made a difference or made a big impact. And the first one that came to mind was a 50-year-old who was in ICU with the diagnosis of anoxic brain injury following a cardiac arrest due to anaphylaxis. So this gentleman was scheduled for placement of a trach and a peg tube at about 1 o'clock that day. The nurses called me down to ICU and they said, you really need to come down and talk to this wife. So I got down there about 11 o'clock and we're talking, and she kept saying, he wouldn't want this. He would hate this. That's not what he wanted. He wouldn't want to be a burden. And I looked at her and I said, then do you want to have this trach and peg tube placed? And she immediately dropped, started crying, had to take 15 minutes. She said, stay here, I gotta go, I'll be back. Come to find out, even though he was only 50 years old and we felt like we wanted to do all these things, the decision was made. That is not what he would have wanted. So we canceled those. He eventually was extubated, transferred to the hospice house, and died about a week later. The wife, who was a physician, wasn't aware that they had that choice. She felt that that was something they had to do. And I think in our debriefing of that whole situation, I think we all felt like because of his age, maybe we should give him time. Let's try to do this. Let's try to do that. And we really didn't take the time to really explain it to the spouse, who I think we assumed also probably had a good understanding of what was going on. But in this case, she was the wife. She wasn't a physician. She didn't know what the options were. So that one, I think, greatly impacted the whole team, ICU, myself, the physicians. 78-year-old patient in and out with heart failure and and chronic kidney disease. How many times do we see that? And they're in and out. Maybe in the beginning it's every couple of months. As they get sicker, as their disease progresses, it ends up we see them every couple of weeks. Eventually gets to the point they're in and out in a matter of a couple of days. Well, this particular patient, he wasn't quite ready for hospice, wasn't quite ready to say, no, I don't want to come back to the hospital. He just needed time. This fella had a elderly, demented wife in the nursing home. And that was his goal, to watch her and to make sure he was there to take care of her. So this one was kind of a reverse thing. I was talking to him. I knew what the plan was. He was not ready to not come back to the hospital for treatment. We as a staff, golly, he's not getting any better. He's coming in more frequently. We're not getting him where he's going to be. He ended up being from home to assisted living and into the same nursing home as his wife. But that was his goal. That was his plan. I was told by his staff, that's not a plan to me. That was this patient's plan. And again, ultimately, one of the last times he came in, we had met several times prior to that, and he'd heard the same story. He knew I was a pretty safe person. And he said, what am I going to do? So between the two of us, we talked about it, and he actually transitioned to the hospice house with the hopes that his wife could come visit, and he died within a matter of a couple of days. So it's not always taking things away or limiting care. Sometimes it's really pulling out, this is what this man needed to do. And it wouldn't have been right or ethical for us to say, you can't come back. If there was still some things we could do, which we were tweaking a little bit. Recently had a referral on a 44-year-old lady on the surgical floor, and I pop up there and the staff, who are you here to see? And I tell them, what are you seeing them for? This lady, at the urging of her doc, was scheduled for a routine gynecological procedure, and her doc had the conversation that, hey, maybe it'd be a good idea to just have something in place. So we did advanced directives. She knew what she wanted. We got the medical power of attorney form in place, and she was good to go. One visit, she had her procedure, she went home the next. 52-year-old comes in with a heart attack. Not too many of us are planning for those kinds of things. It was kind of an eye-opener to her, and she asked to talk to me along with her husband and her 3 kids. Her kids were all about the same ages as mine, so I could kind of put myself in her shoes thinking, God, I don't know if I could do that. She had very specific ideas. And having a heart attack so young, she's probably going to have some problems along the way. And she wanted her family to know, if you put me on machines, you give it 1 week. If I'm not getting better, you better pull the plug. And those were pretty much her words. As hard as it was for her kids to hear that, they needed to know what her thoughts were. And that's what she wanted. We got it in writing. We did her advanced directives. She recovered from her heart attack and went home. I've not seen her again, so that's a good thing. I don't have to see everybody to help make a plan. I had an outpatient with idiopathic pulmonary fibrosis. I wouldn't know the man if he walked through the door, but I had 4 or 5 conversations with him on the phone. He was connected to me through one of our pulmonologists, and he was the type of person, he was an engineer from Iowa State, so we all know how they function. He had to have a plan. So he was home, doing well, was the first visit we had. Things are not getting so good, not going so well. He had to go to assisted living. Talked about that. Then he calls, what am I going to do when we're done with assisted living? I said, well, where do you live? Where do you want to be? Stratford. Okay. He got it set up that when he needed to, he could transition right into the Stratford Care Center, which was home to him. And we talked about hospice. When he was ready, he actually made that phone call to hospice. They got started up there, and he has since died, but was comfortable with his plan. And he just needed to know ahead of time what was available, how am I going to do this? And I never met him. I would have loved to. I think, it would have been awesome, but all right. Management of symptoms. We really don't do a whole lot. However, we recently had a referral. The doc really didn't know what the next step may be. We had a gentleman with severe polyneuropathy from diabetes and just peripheral vascular disease. I contact Dr. Otteman, ask for advice. He looks at the chart to see if there's anything else that we think we can help with this patient. So we can do some of that. I'm not in the position, of course, to make those kinds of decisions, but I do definitely have the support and the backup of Dr. Otteman. So if anything like that comes up, we'll sure take a look and see if there's anything else that we could maybe offer. Advanced directives, I'm kind of going back to that. Everybody does not have to have an advanced directive, and I say that and cringe. Ideally, yes, that would be amazing, but I think it's even more important to at least have the conversation. I met with a fellow yesterday, he was my age, several chronic progressive diseases that he's not going to survive. And now we've thrown some cancer on top of things. And I talked to him about advanced directives. He didn't want to do that because he was afraid he might jinx it. It might jinx him into dying from cancer, is actually what he said, which is fine. But we went on to talk. He has had the conversation with his wife. She knows what he would want, how far to push the medical care, when enough is enough. So even though we didn't do the advanced directives, that's fine. I felt like it was still a win because we had the conversation. I knew they had had the conversation, and that's what it's all about, finding out what the goals are, how far to push the envelope, and how far we go with medical care. I could go on and on. You can tell this is my passion. I love talking with people. But I think I'll stop there. Questions, thoughts?
This is how. Testing. Go ahead, Mike. Oh, there I am. Good.
Larry, you talked about the iPost. Could you just briefly explain how iPost and advanced directives and medical power of attorney differ and what's in common with them all?
Good talk, Joni. So iPost is the Iowa Physician Orders for
Scope of treatment.
Scope of treatment. Thank you. That's what Joni does, is keep me straight. The unique thing about iPost is this actually started out as a different document in Oregon called POST, but we changed it slightly. The idea here is that a patient will have a portable document that can be changed, but it has legal force. In other words, the patient's wishes have to be abided by. Excuse me, a spouse can't overrule it, a child can't overrule it, a provider can't overrule it. It has legal standing in the state of Iowa, and it is a document that is with the patient. It doesn't depend upon the patient coming into Mary Greeley to make the orders happen. We have to write orders that are compatible. So that's what the iPost is. And again, 3 items: resuscitation, level of care. Do you want everything done? Do you want to come back to the hospital for antibiotics or analgesics? Do you want to stay at the nursing home and receive supportive care there and not come back to the hospital? And then do you want tube feeding, yes or no? Do you want a trial of tube feeding? That's it. It's not everything, but those 3 issues are recognized as sort of the 3 that really make a difference. The advanced directive can be lots of things. So McFarland Clinic has an advanced directive that's based on not only the Iowa Bar Association legal document that's oftentimes referred to as a living will, but has lots of space to put down individual desires. Is there a certain situation where you would want a level of care where you wouldn't in a different situation? So that's the advance directive. What was the third one, Mike?
Medical power.
Oh, medical power of attorney. And actually, I think you raise a really good point, Mike, because after 30 years of discussion about medical directives, the pendulum has now swung to the point of what Joni was just saying. It started out as, things like 5 wishes, and, people were going to, write an essay about what they wanted at the end of their life. And nobody did. And that's not a big surprise. The focus right now is talk to somebody that you trust, somebody that can be your spokesman, tell them what your wishes are, make them your medical power of attorney. And so the pendulum has now swung to be as simple as we can make it. And that's really where medical power of attorney has come in. I would say that the advance directive is probably less emphasized in most of the discussions that go on in the field of palliative and hospice medicine.
At what point should the I-post be prepared? Am I a candidate for an I-post sitting here, not a patient, or only when I become a patient?
Okay, so the I-post is a document that can be filled out at any time, number one. It can be changed. And so one of the points about making I-post a portable document is that if you change your mind about the level of care that you want, all you have to do is rip up your I-post, it's your document, and execute a new one. So I think that the general recommendation is that if people have had a change in their life circumstances, sometimes it might be getting married, having a spouse, someone that you would want to be your medical power of attorney. It might be the diagnosis of a chronic but incurable condition. And so it's generally some activity, but there's no one thing that would prompt completing an I-post. A birthday might be it. 85, 90. I mean, you can kind of pick a date where you say, no, I probably ought to get this down in writing. But it's available. We have lots of copies around at the medical center. You can go on to the Iowa Department of Public Health and get a copy. Yo.
Yeah, if you have a medical power of attorney, can they override your I-post?
No.
So if you're in good health and you have an I-post and you say, I want everything done, and a week later you're anaphylactic reaction and you're then anoxic brain death, can somebody at some point say, you're coming off the ventilator? I mean...
I shouldn't be quite so black and white, Mike, because I think ultimately, if a treatment decision has to be made and everyone recognizes that the circumstances in which the I-post was created have changed, then I think you could certainly make a reasonable argument, as you are, which is, gosh, he didn't plan on this. Let's talk to the person who he did share his wishes with. So I shouldn't say the I-post can't be contradicted. So I'm actually thinking of it more in the other way, which if someone said, listen, I don't want to have artificial feeding, a spouse and a child can't come in and say, listen, you've got to feed my dad. But, that's a good example, Mike. So I think that ultimately all of us who are providers are trying to take care of the patient in the best way that we can, which most often is accomplished by finding out what they wanted. Go ahead.
Larry, hey.
Oh, sorry, Jim. And then
Hi.
Evelyn. Yeah.
I'm curious about the intellectually disabled. Is
Okay.
there something that would help I'm thinking Woodward in particular.
Yeah.
help them prepare the people who are giving their approval to have me do stuff to their family member,
Yeah.
often from some other state or
Yeah.
somewhat removed. Is there something that could prepare them so that they know when they get here that they don't have to say yes?
Well, Darla, I don't know if she's here or not, but Darla Hansecker and I spent a lot of time trying to understand about patients specifically coming from a situation like Woodward. I'll summarize it by saying it's complicated. The next thing that I'll tell you is they are actually wards of the state, okay? And in a certain reading of Iowa law, and I will tell you that is the reading that Woodward follows, a judge is required to make those decisions. That a person can be named as a guardian, but they can only do so much. And so it's very complicated. Basically, being a ward of the state means that the state makes the decision. And the way the law is designed, a judge is the state in making the decision.
It feels like to me like the state is so worried about looking like they killed someone,
Yeah?
that they will have us do things to them that you really wouldn't do to somebody who is intellectually intact.
I couldn't agree
It
more.
seems so
Jim.
disrespectful.
Yeah, I couldn't agree more. I don't know that there's a move afoot or anything to change, but guardians of the state are trapped by that very mindset. We never want to be accused of abandoning the disabled, the mentally ill. And I mean, to be fair about it, I mean, in the 40s and the 50s, you'd hear all sorts of statements about people that were abused and misused in state institutions. And the laws were written in response to that abuse. But like all laws, there are unintended consequences, Jim. And so it's not perfect by any means. Evan.
There was a situation back on that, that, in fact, it was the most recent one I've been in on. The guardian paperwork actually stated that that person had the ability to make those medical decisions. So we were able to kind of
To get around that,
bypass that.
yeah.
But that was one out of how many that we get from.
So it sounds
Word
like,
or whatever,
people are thinking of ways of adapting to the current situation, Jim.
Yeah.
But it is very complicated.
Yeah.
Yeah.
With the iPost, explain the nursing home part of that and why the iPost is real valuable for patients who are in nursing homes.
So the question from Melvin here is the role of iPost in patients that are placed in nursing homes. Well, I guess basically, there are some care centers now in Ames that won't admit you unless you've completed an iPost. They're not telling you what to put in there, but they're telling you to think about it. And they don't want to take you as a resident if you haven't. So it's a condition of admission to some, and maybe more than one. Basically, it just gives the nursing home some guidance as to what to do. Probably the key to the iPost is not so much about the resuscitation status. A lot of times people have said, well, I don't want to be resuscitated. But you have this huge population of patients with, indwelling lines and Foleys and recurrent aspiration pneumonia who don't want to be resuscitated, but everybody gets a call at 2 o'clock in the morning saying, this is a resident, they've aspirated, their temperature's 102, what should we do? And people say, well, you better bring them to the emergency room. Well, the ED doc is going to just admit them. What's he supposed to do? Or she's supposed to do? So the iPost specifically has something in there that says, if I get an infection, I don't want to come back to the hospital. That's really the third choice in the iPost. And it was put in there specifically because everyone recognizes that that's a common issue that comes up. Yeah, Mike.
Yeah, who makes the referral to the palliative care service?
Anybody can. Providers. Oh, here we go. Is that on the next slide?
Yep.
Oh, I just said thank you. The next slide. So this is how you make the referral. We've talked about that, Mike.
I mean, if there's a thing, you know,
Can a nurse
somebody's
make
in
a
the-
referral?
Yeah, I mean, if somebody's in the intensive care unit, and
Yeah.
the nursing staff may say, "Oh, we think this is
Yeah.
hopeless. This person definitely ought to be on palliative
Yeah.
care," and the
Yeah.
attending doesn't really agree, or
Right.
how do you resolve that?
And it's a practical question, and it's one that I made, which was we were a new service, and I didn't want to step on anyone's toes, and so we requested that it be a provider referral. Now, we may be well enough established that I don't have to worry about toes. But at this point, Joni, if the nurses call Joni, kind of what we do is that she'll call the provider and say, you know, I've received a palliative care consultation for this patient. Would it be okay if I went to see them? So technically, the referring individual is the patient, is the provider. But frankly, that's why it was, Mike. We didn't want people to get the sense that, you know, we were gonna take over the care of the patient, thinking some providers just don't want to get palliative care involved. But that's how that happened. Other questions? Ooh, 1 o'clock. If people need to leave, we can. We'd be glad to answer other questions, but we've used our allotted time. Oh, one more. Yeah.
Heidi?
Yeah. Yeah, it's a big problem. So the question is, so somebody comes at the middle of the night. It wouldn't be the first time that not every important paper came with a patient from the emergency room, and it happens all the time. I mean, they'll call. They didn't call the daughter who's listed to make the decision, who's really been in part of the discussion because the daughter's gone or on vacation or something. So they end up calling another child who really hasn't been paying any attention to what's going on with mom at the nursing home. And they call him in Oklahoma and say, your mom's got a fever, should we take her to the hospital? And he goes, yeah, sure. So it happens. I guess the best that we can do is, once we recognize that we may not be following the patient's directives, is make as many people aware of that as possible, and try to make the best of a bad situation. Now, you know, a patient getting better can hardly be considered a bad situation. So, you know, if someone came in and they were septic and it turns out that you can give them Mancef and they'll go back to the nursing home, you know, I'm not advocating that we go in and find a culture of E. coli back in the lab and start over again, or stop the Ancef. But, you know, I think it's one of those things where, yeah, things happen. Again, you try to get as close as you can to what the patient wanted to be done, and try to follow those things. All righty, thanks. So do we do this again then?